Now, with that said, why don't we take a moment to introduce our panelists? So panelists, could we please go around and introduce your name, your institution, and the discipline that you're a part of?
MyMy, please.
Hi, I'm MyMy Buu, pediatric pulmonologist at Stanford University School of Medicine.
Carsten.
I'm Carsten Bonnemann. I'm a pediatric neurologist at the NIH in Washington, D.C.
Reghan.
I am Reghan Foley. I'm a pediatric neurologist also working at the NIH.
Gogno.
This is Göknur Haliloğlu. I'm a pediatric neurologist at Hacettepe University Children's Hospital. In Ankara, Turkey. Thank you.
Okay, Alberto. You are mute.
Of course. Hello, my name is Alberto. I'm a neurologist working at the moment in London at the Dubovitz Neuromuscular Center with Francesco Montoni. Thank you for having me.
Thank you all.
Thank you, all of you. And maybe we can start with some of the questions.
Absolutely. So LAMA2 community, this session really is for you. So if at any point that you have any questions that you'd like to ask our panelists, feel free to utilize our chat feature. But we have a couple questions sent in from our family members already. So I guess we'll dive right into our first one. The first question that was asked says, what information can you provide about neuropathy-associated symptoms? What should we be monitoring for, doing, or sharing with our local providers?
I don't know, Dr. Bonnemann, do you want to take this or do you want me or Dr. Zambon? I see you.
I can get started and then you can chime in. So there clearly is, it's an interesting question because the neuropathy is very pronounced actually in the mouse models of LAMA2 disease. And it is quite striking that much of the disability in the mouse is really from the hind limb paralysis that is due to the neuropathy that the mouse has. And it's quite clear that we don't see in our human patient this degree of neuropathy and motor impairment from the neuropathy. However, if you do nerve conduction studies and you measure the nerves, you can see they're also affected measurably on the neuropathy measurements, what we do with our EMGs. What we don't know is how impactful is that on the disability that's caused by the disease. And it's of course very hard to tell apart because both would cause weakness in the legs and the arms. It is my personal bias, I think, and then we'll have other experts weigh in, that even though we can measure the neuropathy, it is not a very prominent disease and weakness driver in our human patients. So even though we can measure it, I think much of the motor impairment that we see is really driven by the muscular dystrophy and not by the neuropathy. We shouldn't lose sight of it though, because once we develop therapies, which hopefully will be soon, and we correct the muscle efficiently, we should be cognizant that not all treatments will address the nerve at the same time. And so we need to be prepared to measure that and at least assess it. It is not necessary to have repeated nerve conduction velocity measurement as a standard of care when the children with with LAMA2, are followed over time. I don't think it's necessary. It's uncomfortable for the children and would not result in a treatment decision. Others on the panel?
Dr. Zambon?
Yes, of course, it's difficult to add something after Professor Bonnemann, but I think, yes, what we know so far, especially in human beings, is that the defect is probably mainly in the maturation of the myelin sheath, which is basically, if you think of the nerve as an electric wire, is basically the rubber or plastic part covering the axon, which would be the copper metal part conveying the electrical signal. So the defect is primarily there, so it's probably more something which has to do with the development, but we know in mice and also in human that this can progress to some damage to the axon. So probably we should be quite careful in the future if therapies comes that these target the nerve as well, because we do not know much about the progression of neuropathy in time. Regarding symptoms, I think from our experience, it's So they are not common. Sometimes patients report some tinglings or paresthesia, but so some sensory symptoms, but of course the motor symptoms are quite masked by the severe muscular phenotype. So I guess as previously said, the problem will be there when we will develop new therapies, and probably we will see the effect of the neuropathy in partial LAMA2. But at the moment, the most honest question would be that we do not know.
Yeah, I completely agree. We had a few cases when I was working in London where patients were referred as having a neuropathy. In fact, they had partial myrosin deficiency. So it can be helpful diagnostically, but we've not been monitoring it in our complete myrosin deficient patients, primarily because, as Dr. Bonnemann says, it's uncomfortable, but something we should think about as a target for therapies.
Thank you all. The next question that we have here is, what is the recommendation for use of airway clearance vests? Our son uses one during physical therapy sessions at preschool, and during our routine pulmonary visit today, our pulmonologist indicated that he does not recommend use of the vests for James' condition. He said these are typically prescribed for individuals with thick mucus secretions, that is cystic fibrosis. I was surprised by this as I see other LAMA2 families using these vests on their affected children. What are your thoughts and recommendations?
Yeah, I think that's a great question. And I think that to address that question, we should take a step back on how the LAMA2 related myopathies, muscular dystrophies affects the respiratory system. So the severity of muscle weakness depends on how much myrosin expression is in the muscle. And so there is a range of severity, but the respiratory muscles that are affected are your intercostal and accessory muscles. What does that mean? So your main breathing muscle is actually the muscle that's between your chest and your abdomen, something called the diaphragm. And so this is intact in patients with myrosin deficiency. And the muscle that is affected is an intercostal and accessory. So those are the muscles between the ribs and the muscles in your neck and other muscles that you use to really heave your chest when you need to do important things such as clear mucus. So the main defects are causing a weak cough and also having that the chest wall itself can be stiff and having small lung size, which then can lead to insufficient breathing. So you need cough to clear mucus when you're sick and then in your everyday life, and then you need lung size to breathe sufficiently. So then comes the therapies. So since the main defect is insufficient cough, then the main therapy is assisting cough. And the mucus itself in your airways are normal. But there are instances where the mucus can become abnormal, such as when you have a cold that develops into bronchitis or pneumonia, then that's when the mucus can become very thick and sticky. Or if you have some swallow dysfunction and now as you're eating or drinking food is and liquids are going into your lungs, and that's causing inflammation in your lungs and causing thick secretions. And so I would say that for patients with LAMA2 MD, really important to have a cough assist machine, and then maybe would need some type of chest physiotherapy machine. So the chest vest, which is a shaking vest, is a type of mechanical electric chest physiotherapy. There are other methods of chest physiotherapy to help move mucus, such as percussion of the chest or other devices that help vibrate the chest and move abnormal mucus. But otherwise, if your mucus is normal, then what you need is just help moving the mucus, and we use cough assistive devices. And there's a couple in the market called Cough Assist from Respironics or from Hillrom called the Sinclaira or the other Vital Cough. So I hope that answers that question.
Yeah, that's very helpful. Maybe I can follow up with the question. Our experience actually, as you really pointed out very well, it is the final cough and getting rid of the mucus that is so affected here, and just mobilizing the mucus with the vest without helping it come out can actually be even detrimental.
Correct. And yeah, and so there are times that a vest may be helpful, such as when a patient is hospitalized for pneumonia, or if the patient has chronic lung changes because of repeated pneumonia or repeated infections, but I would say LAMA2 on its own should not need a chest vest. So I agree with the pulmonologist who saw you.
All right, so on to the next question. In the context of long-term BiPAP use via full face mask over the nose and mouth, is there anything we can do to prevent or slow the development of mid-face hypoplasia? We have the straps as loose as we can.
Yeah, so what that question is asking about is, so not all patients with LAMA2 end up needing assisted ventilation, but some do, about a third do in the severe phenotype, and then less likely if there is some partial Marison. So with insufficient breathing, the way we can help a person breathe is by using air pressure that's pushed into the lung to help a person breathe, usually at night. And the way that can be delivered is either with a mask that covers the nose or nose and mouth, or can be done directly to the neck, which is less seen in patients with LAMA2. So with this question, with using a mask that covers the nose and mouth, that pressure over time can cause the bony structures of the face to change, but that is actually doesn't occur in everybody. So these masks are designed to be used up to 12 hours a day normally for other patients who have other conditions such as obstructive sleep apnea. And so these masks are actually designed to rest on the face and should actually not be smashed against the face. So as the question, the patient who asked this question, like, that it's really important to keep the mask resting on the face. The strap should not be too tight on the face. But then other ways to help prevent mid-face hypoplasia, which is the bony malformations, is to alternate masks. So you should be rotating the mask to different types of masks over time. So that way you have different pressure points on the mask. And then if you're concerned about the way your mask is fitting and if it's optimal for your loved one, then what you can do is work with your pulmonologist or your sleep center to see if there's alternative masks that could be used, or alternative if the way you're wearing your mask is actually accurate. The other thing I want to put a plug in is that while your child may have LAMA2 RD, they may also have the regular things that can cause sleep disordered breathing in children, such as big adenoids and tonsils. So that usually presents as snoring. So I think that having the patient be evaluated for other components of obstruction that could be treated, so that way that the pressure needed to treat at night is less. So I think that's also important.
And I follow up on that here and get maybe input from the other panelists. One particular problem that we see in a number of our LAMA2 patients is an abnormally big tongue that develops over time, which can be a complication in keeping the airways free. I wonder what the experience of our panelists are.
I mean, I've seen this more as the patient's age. And I know of one patient who did pursue a surgical resection of the tongue. It's highly dangerous, of course, but most of those patients have done well. Some of them, admittedly, though, are using the nasal interface. So their mouth is wide open anyway, baseline, but they're using the nasal interface, and the tongue may be large, but I haven't encountered it as being too large, personally. I don't know, Dr. Zambon. But I think a great point about the question of also large tonsils. So in very young patients with LAMA2 related dystrophy, it can be the case that they may be playing a role in the breathing because most of our patients with LAMA2 related dystrophy do not start non-invasive ventilation too early. That being said, we have some, 1.5, 2-year-olds on non-invasive ventilation, but most would be around age 5 or 6. So if there is a question early on of obstruction that maybe should be acknowledged and addressed, and it's a huge point, because later on there will be that more restrictive or lack of chest wall movement issue. So I think parsing out the two is complicated, of course, but very important.
Oh, Reghan, maybe I can just, extend my gratitude for this CMD pulmonary guide. because that really helps for physicians who are not used to see these patients, not the pediatric neurologists, but the respiratory physiotherapists, and also general practitioners, pediatricians, and also the pulmonologists who are not exposed to these conditions in different settings. I mean, for instance, sometimes we have the difficulty even in our center, different ideas from the pediatric intensivists and the pediatric pulmonologists. So that really creates a chaotic environment for the pediatric neurologist staff. So many thanks for the CMD pulmonary guide that really leads not only for the patients, but also for the caring physicians, covering all of the elements as well. So I was wondering, in different settings, when you don't have the opportunity to access for polysomnography, do you believe the artificial intelligence will play a role to monitor pulmonary function at home or a different setting? Or can there be some non-invasive pulmonary function tests, especially for those kids who are not cooperative, for small kids? Thank you.
Yes, I believe the question is, what are alternatives ways to monitor pulmonary function besides what we have currently, which is in-lab polysomnography, which are sleep studies, or pulmonary function testing, which requires a cooperative patient who we usually try starting around 5 and older. So those are all things in development, right? So in terms of in-home sleep studies that is in development, that's already being used in adults. And I think that the challenge in pediatrics is keeping those leads on in a home environment, and then also having CO2 measurement in the home environment, because a lot of this, a lot of the effort is around sleep disorder breathing, obstructive sleep apnea, as opposed to hypoventilation in patients with neuromuscular weakness. But I think that the field is moving forward with home monitoring. In terms of lung function, I think that is challenging. And there are groups such as my own who's involved in looking at ways to measure lung volume, such as FRC and vital capacity using passive measurements that don't require patient following instruction with tidal breathing. So those are also in development.
I don't know if Sean Pascoe wants to comment on this. I'm trying to give you access to unmute.
Sorry about that. There we go. I was trying to take my video, turn my video on as well, but I can't. Okay, that's fine. I can talk. So I do pulmonary and sleep medicine at Cincinnati Children's and have an interest in kids with neuromuscular disorders, of course. As far as that, your question goes, for home monitoring, there's really nothing out there right now, unfortunately, for kids. And the really important thing is monitoring end-tidal carbon dioxide. And there's not much in the way of home end-tidal carbon dioxide monitors to go along with home sleep studies currently. And as Dr. Buu said, sort of keeping leads on and everything like that can be very challenging. One thing sometimes we consider is doing overnight oximetry studies just to get an idea of DSAT, like average saturations or a DSAT index. There is some data there that you could go off of. And then the other thing too is just sort of the clinical history. If there's the child's not sleeping well, waking up many times at night, wakes up with a headache, is irritable during the day, maybe above and beyond what you might expect for the age, then those are all features of maybe they're not getting great sleep, and or if they're sleepy during the day. It may be something that you could, even just with that information, consider doing like a bi-level PAP at nighttime. And then you could, it's not all the time that you see compensated chronic elevated CO2 on a renal panel, but if it's there, it would make you really suspicious for maybe the child's hypoventilating at night. You can't hang your hat on it if it's normal. It's not, doesn't necessarily mean that something's not happening at night, but it's just sort of an added tool you can use.
Awesome, thank you.
Those are great points. I actually often say to parents that if the child's awakening, I don't know, my sense is over 5 or 6 times a night to be quote unquote turned, it may be because they're waking up because of inadequate ventilation. So that's a great point to make.
Justin, we have the next question.
Of course. So moving on, another question we have here. Can you describe typical findings on an EEG for LAMA2 patients? If an MRI has yet to be performed, should we get an MRI? Is there critical information we can gain from an MRI?
Should I start?
Maybe Dr. Zambon, do you want to take a stab at that?
Thank you very much. So I think so. The premise is that seizures are quite frequent in LAMA2, and probably the prevalence would be around 20 to 30% after the age of 6. And again, of course, we gather our information with very limited data. So of course, this is what we know so far. And the other thing important to say, I think before, is that in the MRI shows that typical white matter involvement, which has not a meaning of something, a damage of the white matter, but probably something else, and it's not correlated with epilepsy. And that's quite useful for the diagnosis, but probably not useful for having a clinical indication if seizures are going to happen. And then the other thing we can find with MRI are defects in neuronal migration. And again, most of the time, so this will be present in roughly, I think, 25% of patients, maybe more, specifically if we look with more care at the occipital areas. And most of the time, this will be located in the parieto-temporal or occipital areas. So, and when the defect is large, as demonstrated by a recent work by the Spanish group, I think this correlates with the risk of epilepsy. But it's also true that some other kind of defects, such as polymicrogyria, is quite common and probably has not a good relationship with the risk of epilepsy. So that's these are the premises. Having said that, so the epilepsy is common and most of the time would be a focal, meaning that the manifestation is not tonic-clonic seizures with loss of consciousness. And I think it's important for clinicians to know that it's common to have occipital or parieto or temporal region. And this is important because when the abnormal electric signal starts in the brain, this determines the kind of semiology we see, meaning the symptoms we see. So I think given that the high frequency of occipital seizures, we would expect symptoms such as vomiting, or the child could be pale or having malaise, so not the typical abnormal movements of the limbs that we would expect. So we must be careful because sometimes the kind of what we call autonomic symptoms are not so easy to recognize. So I think that maybe answer part of the question. And then I think the other part is probably one of the questions was asking about the therapy. And I think from some of the cohort described, we know that in many cases, we need more than one drug to control seizures. So that's the other thing. But I think, again, it's difficult to draw a meaningful conclusion and say there's a strong correlation because we base our knowledge on very limited data. I'm not sure what the other panelists think.
Well, it's a great summary. And let me just extemporize a little bit on some of what you said, which is very important. So this difference in the back of the brain is actually not that uncommon in children with LAMA2 related dystrophy, but it is not directly, as Dr. Bonnemann was saying, unless it's really big and really extensive, it's really not directly related to epilepsy, nor to abnormalities of vision. Some of you may know that in the back of the brain, that's where the vision is controlled and vision is processed. And even though you find these abnormalities on the MRI, the children with the LAMA2 related dystrophy do not have obvious visual defects. And that's probably because that developed in development and the brain has figured out a way to remap these functions and use other parts of the brain efficiently. It's also important to mention the flip side of it. So even if these abnormalities in the back of the brain are not seen on the MRI, it doesn't mean there couldn't be epilepsy. So some of the seizures can be generated from that part of the brain without obvious abnormalities on the MRI being present. It's important, what Dr. Sambon pointed out is what he meant by semiology. Semiology means how the seizures are clinically recognizable or manifest or experienced by the children. And that particular part of the brain, in the back of the brain and surrounding areas, can cause weird and strange seizure that you wouldn't kind of think this is a classic seizure where the patient goes into rhythmic contractions, but rather it may be as subtle as feeling unwell, having a sudden belly pain and nauseation and vomiting, or in some of our patients, I report that they see all of a sudden red balloons floating around, which is also coming from the back of the brain. And so those would be indications. So if the child is suddenly pale, vomits, has belly pain, not quite responsive, doing that, that would be an indication to get an EEG to see whether there is seizure activity from that, or when there's red balloons and headaches coming from that region. It may be different from center to center, and everyone can comment on that. We tend to only do an EEG if the suspicion arises that this could be happening. And so let's say there's a child with this unexplained autonomic belly features, and then we say, well, we need to make sure this is not a seizure that we need to treat. But we don't do routine EEGs just to see whether anything is popping up back there in the brain, because you would not treat an electrical discharge from the back of the brain that has no clinical consequence to it. But maybe Dr. Haliloglu can also comment on that.
Thank you. I totally agree. I mean, we do not routinely do EEG studies in our patients with merosin-negative congenital muscular dystrophy. But just from another, sometimes these patients are referred because of the diagnosis of a leukodystrophy. So at that time point, it is not a leukodystrophy, but it is a congenital muscular dystrophy. So you have to prove that that is a congenital muscular dystrophy. So sometimes when the families, especially when there is a for leukodystrophy, can be a bit low than a congenital muscular dystrophy. As you say, thankfully, these seizures, when they are present, at least in our hands, is not drug resistant. I mean, I do not recall any patients that we didn't control the seizures with routine anti-epileptic drugs and the new generation anti-epileptic drugs that we have in our hands. So I think any change in behavior or any abnormal, staring, as very nicely indicated in nausea or some silent semiology that can be linked to seizures, it should be an indication for an EEG study as well. Yeah.
And I love that we touched upon seizures, because this brings us to another question asked by our families. What is the estimated occurrence of seizures in LAMA2, and by what age would we expect to see seizures if they are likely to occur?
It's back to Dr. Zambon, who has all the data about it.
Yeah, so I think it's around, so the median age normally is around 7 years old. So I think by we analyzed our cohort, but also by other reported cohorts, would be rare to see seizures before the age of 6, even though, of course, exceptions are there as always. And so I would expect that to happen around the age of 7. And as I said, probably the more true estimate would be 25 to 30% of patients. I'm not sure if Dr. Bonnemann and Professor Bonnemann and Dr. Foley agree, but I would say after the age of 6, probably around 25 to 30%. And probably a question we didn't answer before, like whether to do the MRI or not. I don't think probably it's useful to repeat MRIs in time, because we do not expect progression of the abnormal signal in the white matter that, as I said, and as the other panelists said, it's not an expression of a leukodystrophy, so we are not extracting any useful clinical data from that. And the kind of abnormalities which are more related to seizures are abnormalities of the development of the the brain and of the cortical neuronal migration. So it's not something we would expect to change in time. It's something which is there from the beginning.
Yeah, that makes an important point. So if the seizures begin, it doesn't mean that disease is now entering a degenerative phase or something. This is really, even if the wiring has been different from birth, sometimes the seizures take their time to appear or never appear. It also means if they don't come on the clock by 6 to 7 years of age, sometimes they're earlier, sometimes they are later. It doesn't mean it's not a part of the condition. So they need to be recognized because they can be treated, but they don't mean the disease is entering an ominous phase or this is a particular severe case.
And sorry, just one very last thing. I think from the work from the Spanish group, there was one patient demonstrating cognitive regression, which means that basically a child starts behaving in a different manner than before and is not performing as well at school, and so it basically changes what his standard is. And we do not expect that to happen in LAMA2. And in that particular case they described, there were continuous epileptic abnormalities during sleep. So this is a well-recognized cause of cognitive regression. So regardless LAMA2, you would, if you see a child who's 10 or 9 and is going back, of course, you need to investigate and to rule out that nothing is happening. And I think particularly in LAMA2, if this happens, you should do an EEG during sleep because the epileptic abnormalities during sleep can cause this and can be treated. So
exactly,
because that's one only cases, but I think we should have the
extremely important to recognize and to treat. Absolutely. Justin.
I believe that's most of the questions that our audience members have asked us, and this actually does bring us to a close. We are running out of time, so I think it'd be best if we finish off by having each of our panelists with a little closing statement or a take-home message for our families and affected individuals. Dr. Foley, would you like to start?
Gee, thank you. I think just kind of want to reiterate some of the message from this morning and make it more LAMA2 specific. I think as most of the families who are listening now know, it's a very exciting time because we do have therapies in development that are realistically progressing forward. And so we are obviously very focused on, we mentioned optimizing clinical care, identifying good outcome measures and gathering that natural history data so that we're really ready when those trials begin. And I can't thank the families enough for their collaborative nature and being so open to gathering this data with us. But yeah, we're realistically optimistic that we're going to have trials coming, which is great.
And I can follow up directly on that, and I think that's absolutely true. So two things from the morning session. It's really important to establish this optimal medical care that we've discussed here on this panel, from pulmonary to neurological care to neuromuscular care, to keep everyone clinical trial ready and in shape to do that. And I also want to assure, even though we talked about outcome measures at the very early age, because that's when we want to start treatment, it does not mean that children who are older or even adults would not qualify for treatment. It does not mean that there is a door that shuts on you, but we want to capture all the ages with this condition to really be able to test and trial and bring treatments to patients at any age.
I have to agree that this is a really exciting time. And so as a care provider, I think that what I'm trying to teach my colleagues is really to preserve functionality of our patients as these therapies are rolling out for the whole lifespan. And as a pulmonologist, you know, the respiratory insufficiency is the main issue in LAMA2. And so starting interventions early and starting the right interventions is really important.
I think also, apart from, of course, therapies which we hope will come to clinical practice soon, but we also know more about the disease. I just quoted one of the epilepsy paper which just came out last year. I think we know more about the disease and we know more when to expect complication to happen. So on one side, we need to be aware that every patient is unique, but on the other hand, if we know when to expect things such as respiratory failure or feeding difficulties or scoliosis or orthopedic evolution, so we can anticipate. So I think there's also a good moment for, we are improving our knowledge. Of course, we are far from having a strong knowledge about the disease, but still it's better than a few years ago. So I think also for patients, it's more clinicians can access this knowledge and can be aware of what to expect and to anticipate.
It is really fascinating to see these toolbox, not only for the treatment opportunities, but also for the outcome measures, as Dr. Foley very elegantly discussed with us today. So looking at the phenotype in detail, I mean, the natural history, the respiratory phenotype, we are each day learning a lot. And I think, as the panelists indicated, care and cure must be going head to head. And so there must be no deviation from the routine care that we have to provide to these patients. Thank you.
Well, thank you very much to our panelists for sharing, and thank you to our audience members for dialing in today. If you do have any, if you would like to continue this conversation, we would like to direct you to the community lounges after this call. In other words, thank you so much for joining us today. We hope you enjoy the rest of your SciFam experience, and we hope you have a good rest of your day.